We used the wedge as we took it into extension. We blocked up the knee so to be relatively comfortable. Okay, and then I took this forwards at this end like this. I came over the end of the bed and I held this up over the end, you remember, and came into here and pushed downwards like this. And then I did the two techniques of medial and lateral rotation. First the lateral rotation, hold, push down, and then the medial rotation coming here, holding there, so we don't stress the knee particularly, and then just come with this short lever technique from above, like this. So this is getting the correct glide associated with those movements in a joint where basically the biggest movement that takes place, probably artificially, that we do, is the distraction. So let's have a look at those two, or those 4 or 5 techniques. Thanks, Ben. Yeah, thank you. Feelings and understanding about use of quadrants. When do these get used? All the time? Quadrants, yeah.
As opposed to combined motion or planar? Quadrants as opposed to planar?
Yeah, the quadrants of the hip, which would be flexion, medial rotation, adduction, or flexion. Yeah, I think this is a thing that it's a provocative test. It's a test where we are going to the extreme, presumably, of the ovoid of motion. When Maitland originally did the observations on it for the shoulder, this was a thing that was used when there was full movement, when isometric contractions produced no pain, and you were kind of trying to sort of stress to see if some part of the joint there was some limitation of slide or whatever at that particular range. And of course he found that there was this peculiar little thing with the shoulder where it seems as though it kind of climbs up and goes over a small area, whatever this is, but it's some part of that ovoid of motion, so that when you're coming into this position and you come around like this, what you should do is you come up like this as you feel you come to there, and then it comes up and over and it drops down the other side. And what he found was there were many patients you could not do this to. So you had to kind of sort of glide in and around these movements until this particular feature seemed as if it normalized itself. And we took it to a greater degree now, which was to look at all of these movements in the hip. And so now we're going to come into a position where we go into an internal rotation and adduction and flexion, and because we're coming up into this range which is quite stressful, we should be very careful, and we're going to sort of try and move over that ovoid of motion, like a little scouring motion in fact, to see if we can get further and further into range here. And the other one would be to go into the abduction flexion pattern and coming around here like this. Of the two, I find the flexion adduction probably the most useful and the most usual. But this quadrant movement, if it's done carefully, is very useful in terms of early osteoarthritic hips, or to do it when you've got quite a bit of improvement in osteoarthritis. The use of the Faber as an exercise is also extremely valuable. So with Jeff here, if I come down into this position and look at this, I can almost treat this the same as if we were dealing with a flare, except I'm going to eliminate the ilium, ilium by going underneath the ilium like this, coming out into this position, asking Jeff to just resist me. Now just hold and let it go. Let your leg go down. So we'll use an isometric antagonistic technique. Just come up again and relax, and now I can use an isometric or an isotonic agonistic technique. Pull down and out. If you can move it, it'll be an isotonic, but in both cases, as I'm saying, move it. From what Kent was telling us, both of these would be a contract relax, because the intent is to move. Down again. Right down like this. Okay, so just under the ilium, and because I'm doing this with the ilium, okay, and it's going into out flare, I'm getting hold of it and pulling it back into in flare. And it's a little bit like that modification we did of the Faber to try and check out whether it was in the hip. I'm going back into the stress of the hip position by reducing the stress on the sacroiliac joint. So those are actually the quadrants and this. I saw one of the, a tape that Clifford made, or I saw, no, some notes, that was right, some notes that somebody had taken. Really, you know, these people that can take excellent notes on courses. And this had come out as, this is the Fowler exercise. And that in most people, exercise for osteoarthritic hips doesn't do any good. But with the Fowler protocol, 6 weeks later, wonderful improvement. Now, in actual fact, this is not the Fowler exercise, but that's how it was put down. But it is actually an incredibly useful thing. We laughed a lot about Fowler's exercise. I was asking him, are you going to publish this exercise? Okay, so just coming around like this, asking the patient themselves, because you don't just want to free up the pelvis, and so wherever the wedge is, that could just be, or a towel or something, but the wedge is ideal to just go under the hip like this, and then just to sit there and go down like this. And then gradually try and get the hip into more flexion. Now, I'll show you something here if I can. I will come to this side of the table here and sit down. Okay. Actually, let me go onto the table myself for a minute. Here is my Faber done on the left side. Okay, that's reasonable range of movement. This is it done on the right side. There. And at one stage I really worked on this and I got it right the way down, but unfortunately I'm like your regular patient. Once it was all right, I stopped doing it anymore. And I just used to sit down and watch television. Now then, if I go down into this position, I don't know whether you'll be able to see this, Dave. If I go down into this position here and sit and put my leg up like this kills me. There. I don't like it. Okay? So what I think is the thing to do is to get a whole pile of newspapers or magazines or something and put a tape around them so you've got a little stool. Okay? So now what I'm doing is sitting at about this angle against the Chesterfield watching the television. Okay? And I just put my legs out like that. I better not go anymore, so I'm going to split my trousers. Okay? Which would be somewhat embarrassing. So just going out, and then as I find this becomes easy and I can push, I just keep taking away an inch or so of the newspapers until I'm sitting down on the ground and put it out. It took me about 2 months to get it out to the side, and it was highly effective. The hip was painful, and then it sort of stopped being painful anymore, and I got good range of movement. Now it's stiffening again, but it's not particularly painful, so I haven't had a great urge to do much about it. But it's stupid, because this is the time I probably should be doing something about it, when it's not too uncomfortable for me. So that Faber as an exploration of a person with osteoarthritis and an early movement is a wonderful exercise. So the quadrant is very important. The Faber is an exercise, and particularly with these modifications that I've mentioned to you of varying the amount of flexion, going into more and more flexion, which is bringing in that third law of Friot, and also the efficiency for me, because if I go right down, my leg's in this position, I can't kind of put a bit of weight on it, but where I'm sitting up, I can kind of press down on my knees and do a little bit of work on here. And of course, it's very simple. I can get my little bits of tubing. I mean, I've practiced all of this. My little bits of tubing around my knees and just sort of pushed it out to the side against this. So I was working those external rotators as I was doing this thing. And it worked very, very successfully. So I'm usually very positive when I tell patients about this. I go through my own experience. I sit on the floor and I show them this. And I say, look, I'm no different from you. And look at this. Isn't that pathetic from your therapist? Oh, yes, yes, yes. And I say, I did get it down, and now it's back because I didn't keep doing it. So what's the message for you? I should keep doing it. Yeah, yeah. At least they know I'm empathetic, Pat. Trouble is, if you've got the same problem, I'm not sure that you are all that empathetic. Yeah, I'm living with it. Okay. The other thing was how Brian was doing this, and this is kind of useful, if you can just come on, Brian. This is one of the techniques that Olaf uses for stretching the adductors, in this position, which is to use the forbear in this position, of just coming up here, and then coming into a position where I can do this. And also, if the patient is up in the air like this, at this range, he'll put a belt around here and just keep tightening it up a little bit. And as it goes down, a little bit more. And a little bit more. I guess Norwegians are tough. Sort of coming down here. So to go into some of these variations of this is quite a useful continuation position. So let's just try the quadrant because it's prone to being overdone. I don't mean overdone as a technique. I mean simply as one person we can overdo it a little bit because it's such a kind of thorough exploration of outer perimeters of the joint movement, and also try that forbear with a hold relax, contract relax, or the isometric, whichever terminology you're happy with, the isometric correction or the antagonistic agonistic techniques. Okay, let's just try those. And all of these techniques, of course, that we're doing, if I were in that external.
Good.
Okay, go. I don't think we've had. Have we had you on video? Just lay back on, yeah.
Having a bad hair day.
Yeah.
Of course, every day's a bad hair day.
Okay. If we talk about joints, okay, one of the considerations in many joints is the development of painful bursitis. And many of the joints we look at, particularly the knee and particularly the shoulder joint, there are many bursae around these joints. Now, in the hip, there seems to be three that causes the problems. One that seems to cause more problems than than the other two put together, and that is the trochanteric bursitis. A British group that looked at this felt that we shouldn't be calling it trochanteric bursitis because we couldn't be absolutely certain that it was the bursa. I mean, do we know that it's the bursa and not a low-grade tendonitis, let's say, of gluteus medius? And they said, in view of using these specific terms for a syndrome, why don't we call it the name of the syndrome, which is just, they called it, this is the treatment for lateral trochanter pain. Local lateral trochanter pain. And they felt that a cortisone shot in that area was fairly efficient. But the three bursa that are important here are the trochanteric bursitis, the psoas bursa, and the ischial bursa. The trochanteric bursitis, unfortunately, doesn't seem to show up, I've found, in all of the things that you would expect. For example, you'd expect it to be painful here. You'd expect it to be painful when you went into the Trendelenburg, and especially you could aggravate it by exaggerating the motion like this. This would seem to be reasonable. That when you did an isometric medial rotation or an abduction, it made it painful. That when we came into this position and we stretched across like this into a stretch position for those medial rotators, that made it painful. And then when we went in and we palpated, we should find the point just a little above and posterior to the lateral trochanter, the greater trochanter. Unfortunately, half of the time, only perhaps one or two of those things show up as being positive. And sometimes none of them show up as being positive apart from pressure, which always kind of agitates us when that's the only way that we can find it, in terms of like a trigger point would show like that. And so I think this is really important to try and look and be happy if we can find these. What do we do about treating them? Has anybody got any great system for these? I found that ice is a lot better than using heat, and I do that on a regular basis with patients, say 4 or 5 times a day. Just stick some ice on the outside of your hip here and just read or something while it's on for 15 minutes. How this fits in with ultrasound, which essentially is giving heat to the area. If it's acute, of course, I use pulsed ultrasound. Generally, I never use pulsed. I always use continuous. And I use it here with 15% dexamethasone in the gel, which I found to be much more effective than any other procedure that I've used. Because I think that we should be doing this, I go through a series of soft stretches into adduction to try and at least make some difference to the iliotibial tract. But I must say, I don't do it in what is the most efficient way for doing the iliotibial tract. A, because they've got to lie on that painful side to do it, and B, because I think it might be too stressful, it makes it more painful. But I do some just coming into this position here and laterally rotating here, so that I try and make sure that at least I'm stretching the minimus and the medius a little bit by a slow stretch. And then I start to do some fairly moderate isotonic concentric contractions around here before I ask them to do very much in standing. The other thing that I usually suggest to people with a trochanteric bursitis is that they always stand equally distributed. They don't stand like we mostly do and sort of just hang from one hip. That's a no-no for them. And so that's what I do with this. And if it's very sore, although I haven't seen one of these for a long time, I think sometimes you just have to put them on crutches. But I've never found anybody that thinks it's serious enough to put on crutches. Okay, so that's the trochanteric bursitis. And the sensation for that is just to come over the top here and posterior to the trochanter. Now, how about the psoas bursa? What's that doing? Where's the skeleton? Are we? Thank you. Great, thanks. Where's the psoas bursa? This is situated here, isn't it? On this kind of pectineal line here. It's quite difficult to find, and there's a very good picture of this in Reed's book, where they've actually put some radiopaque material in the bursa, and the bursa actually appears to be sitting just above the lesser trochanter, not in this position here. But this is where we normally find it, so that when we do a resisted isometric flexion of the hip, it hurts. But when I do the same thing in a flexed position like this, it doesn't hurt, because we've lifted the tendon away from the bursa and it's not compressing it against the pectineal line of the pubic ramus here.
Could you repeat that again?
Yes, that if we go into flexion and flexion hurts, and then I come into a position like this and ask the patient to pull up in that position, that doesn't hurt. And what we may have found in our scan was that things like extension hurt in the front of the groin. And then when we kind of came into this position, we didn't really find very much. So that makes us kind of wonder about directly in front of the groin. So this will be a good point for us to sort of do a little palpation. Okay? If we just take the leg into a gentle rotation position of lateral rotation, a little bit of flexion, we come across and we position ourselves on the adductor tubercle. Then we come along and we feel the anterior superior iliac spine. Coming along there, we've got the inguinal ligament, haven't we? And that is what? The underfolding of the external abdominal oblique. Very, very interesting structure, especially in the male. Because if we look at this underwinding here, we've got the deep inguinal ring about halfway along, and then the spermatic cord lies in this underlying part here to come out where the inguinal ligament splits just above the adductor tubercle. And that's why in males it's extremely sensitive to press, and that's where, of course, inguinal hernias track down along there, and that's what Reed was talking about here. So that's probably, you know, a more common problem. With women, you often get, which you don't see much in men, I've never seen one anywhere, and I mean you don't tend to sort of see these because there's not patients that are sent to you unless they've got one of these, to see femoral hernias. So if we can just orientate ourselves on this triangle here. This is the femoral triangle, isn't it? We've got the inguinal ligament here, we've got the sartorius, which is coming down here, and we've got the adductor longus, which is here, and then coming across we're going to have pectineus, psoas, iliacus. And in the middle of that little group, we should be able to feel the femoral artery. So this is quite difficult to palpate because we've got those femoral vessels sitting in the middle of the base of this triangle. Because under there, we'd find this bursa. So it's quite difficult to sort of feel this. So largely, we're dealing with what does happen on flexion, and does this alter considerably when we reduce the pressure by coming up into this position. So a little bit of a review for yourselves on that particular area would be sort of valuable. Now then, the ischial bursa. Do you remember the anatomy of the ischial tuberosity? Do you know the two areas of this? If we come into here, that the ischial tuberosity has got a squared area like that, and a kind of roughened area like this, and that this squared area is divided into two like this, and if this is lateral here, semitendinosus and biceps is coming from here, and semimembranosus is coming from above there, and this upward continuation is of the sacrotuberous ligament, which is as if it's almost the upward continuation of the long head of the biceps femoris. So what we've got to do is to bend the leg up and to see if we can sort of feel this area here. This is what used to be called a weaver's bottom. Okay? Because of sitting, as weavers did, with the leg up in the sartorial position, hence the name sartorius, of course, for sartorial elegance, okay, and then coming out here and sitting on this and just making it sore. The treatment I found for this, and the about 2 or 3 I've ever seen, was to do ultrasound, to do ice, and just to give them something soft to sit on for a while, or just tell them get something soft to sit on, and not to sit around too much when they're at home, lay down on the Chesterfield or whatever. But with this is to take it into a position like this, to palpate round on the bursa itself, and then just make the muscles work a little bit, just pull downwards a bit, and see if you can isolate the muscles a little bit, because we've got to try and isolate this from a tendinitis of the hamstring muscles, although it doesn't alter it very much. But you may be prepared with a chronic tendinitis to do deep transverse frictions. If you tried that with a bursitis, it would just make things a whole lot worse. So here we are. I mean, we needn't sweat very much about this because I don't know how many times you'll ever find this, but patients that have perhaps fallen on it or sort of hit themselves on something, kind of some projection, or been sitting around too much on something that was too hard and perhaps rigid or something like this. This is the kind of group that gets that. Certainly I don't think we find weavers that get it now, that sit around too much. But perhaps as Becky's sitting here, that could perhaps cause that problem, sitting on the floor.
And sitting on a really hard plastic seat.
Yeah, might do. Yeah, 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 yeah. Have you found in cyclists, that's a good point, and I thought about that myself, and I thought, geez, you know, now if people are cycling, I haven't seen any more of these.
You just expect to hurt. I mean, when I go out and ride for I mean, I'm a professional cyclist, unless you bounced a lot on mountain bikes and came down on a line,
Yeah.
you can do it.
Yeah.
But I think there's a certain amount of pain that you figure goes along with the activity. You're young, you heal fast, so you take anti-inflammatories and you never end up in PT.
Yeah. Yeah.
Yeah, I think it's probably a self-resolving,
Yeah.
self-managed thing.
Yeah.
If it's dinosaurs first.
Anyway, can we just do a little palpation around here? And remember what we did yesterday, because this is the total palpation you can put together in your head now, okay? That we had a look at the gluteal region. We palpated in there for things like the ischial tuberosity. We felt the sacrotuberous ligament. We had a look at where the piriformis was. We could feel down where the back part of the sacroiliac joint would be. We tested out the piriformis. We could kind of move across and look at the gluteus medius and minimus and gluteus maximus by palpation. We did all that in the posterior area. We should now link this with the sign of the buttock, if we were just thinking about extreme sensitivity in the case of osteomyelitis or sort of fulminating infections or fractures or whatever. Or we should perhaps feel an enlarged mass if it was a posterior iliac fossa mass, or if there was some inflammation going on, it would be hotter. So that would all fit in now with our palpatory assessment. Then we went into coming around into the medial groin here, coming up on all those structures and making them work. So that fitted in a whole lot of stuff then. Then we just had a look at what can we palpate in this area here, coming around and looking for these tendons, making the, can you just push out, just not so much turn out, just lift your leg away from the other one. There. And so we can actually look at the tendon action around here and palpate this, and then we can come across that inguinal line here looking at the various structures. And sometimes it's just a matter of just, you know, pressing in and thinking, right, what is that structure that could be there? Now, supposing I think in terms of pectineus there, can you just pull upwards a little bit in that direction there, as opposed to for the psoas or the iliacus pulling up a little bit there, like that. And it may be, I don't know that we can split the action of iliacus and psoas. I fiddled around on a number of occasions doing various things with the spine, and we can just talk a little bit about that when we do the 4 or 5 stretchings that we'll have time to do around here. So can you just sort of think about that whole area from a manual therapy palpation point of view, because we've done it in 3 or 4 different sections, and I'd like you just to sort of link it in your brain now as to what we've done in this area for palpation. Then it will be a complete picture. All right? Let's just do that now, please.
Is there anything special you do for the psoas bursitis?
Psoas bursitis, I had a lot of problems with this. I'm a little bit worried about using fairly intense ultrasound in this area, so I tend to use pulsed, I must say, and I use one of the Chronosonic machines with that great big head. You know, just stick on, because of I was a little bit concerned about where we've got blood flow that we're actually going through an artery, where if we're going to produce vortices and all this and clotting, I don't know whether, I saw some work once that sort of suggested that this is probably a consideration, and I kind of never forgotten it, but I've never seen any supportive evidence. I'm always a little bit concerned. However, what we could probably do is to come into this position like this, palpate where the artery is, and then perhaps get as close to it as